Uh, Welcome, everybody. Welcome to today's Grand Rounds. I'm Dr. Panju. I'm covering for Dr. Azam as your chair. Today's Grand Rounds, we have 3 of our PGY3s presenting medical Grand Rounds, and the topic is concerning the trajectory of opioid use disorder and opportunities for interventions. Lesson learned from clinical practice, research in the fentanyl area. Our 3 presenters are Brittany Dennis, who is graduated from the United Kingdom for medical school, is one of our residents, completed an HRM PhD, and will be going into a fellowship for general internal medicine, and will be doing our clinical investigator. Our other presenter is Elon Pogue, completed his medical school in Poland, and will be going on for fellowship for internal medicine. And finally, Kate Lovett, who completed her medical training in University of British Columbia. She's one of our internal medicine residents and will be going off to a fellowship in BC for hematology. I think I will let you guys start presenting, and we'll have time at the end for questions.
Okay, thank you so much, Dr. Panju. So we'll be presenting today on a topic that's very near and dear to my heart, and we'll be talking about the epidemiologic trends of opioid use disorder since the onset of the crisis. And we'll also be going through some data from a study going on here at McMaster, as well as summarizing some preliminary data from our inpatient addiction service led by Dr. Leslie Martin. So next slide, please. And we have no conflicts of interest to declare. Next slide.
Okay, so to get started, as you all probably already know, the opioid epidemic is a public health crisis, and the incidence of opioid-related fatality is unparalleled to the rates observed in North America. These rates have climbed 500% in the last 20 years. In fact, it is estimated that 136 people die each day in the US from opioid overdose, such that it is now the leading cause of mortality in people under the age of 50 years of age. These 3 graphs are visual representations of mortality rates from opioid overdose across Canada in 2016. In 2016, 2020, and in the first 3 months of 2021. The darker shades of purple represent higher mortality rates, and the small circles in the center represent the crude mortality rates in each province. As you can see, there were 2,800 deaths from overdose in 2016, and this doubled in 2020. The most striking finding of all, however, is in the rightmost column, where we see over 1,700 deaths occurring within the first 3 months of 2021, bringing us close to the number of cumulative deaths in 2016 at the onset of our recognized opioid crisis. Next slide. The number of opioid-related deaths across Ontario significantly accelerated in months following the onset of the COVID-19 pandemic. In 2020, there was 2,426 opioid-related deaths in Ontario, an increase of 60% of opioid-related deaths from 2019. When we look at this as a rate, the rate of death from opioid overdose in 2020 is 400 per 100,000 deaths. To give you some perspective, the rate of death from COVID-19 in all of Canada since the onset of the pandemic until October 2021 is 70 per 100,000 deaths, almost a sixth of the deaths attributed to the opioid overdose. Even amongst the groups of highest risk of death from COVID-19, those aged 65 to 84, we see that the rate of deaths is almost a quarter of those caused by opioid overdoses. The point here is not to undermine the COVID-19 pandemic, but really to highlight the impact of the opioid epidemic. The impact of the COVID-19 pandemic has not hit us all equally. We know from provincial data that even amongst those with opioid use disorder, the groups listed on this slide are disproportionately infected. Those include patients who are incarcerated, living in rural settings, or who have lower socioeconomic status. It's not hard to imagine why this might be, as those patients have less access to care, may not be able to socially isolate, and may even have multiple undertreated comorbidities, placing them at higher risk of COVID-19 complications. Next slide. Now, opioids have been around for decades, yet it is not until the 21st century that we begin to see the opioid crisis climbing up the public health priority list. So what exactly happened? How did we get here? Kolodny et al. Provides a detailed historical account of the current opioid crisis in the United States, which we have briefly summarized here. One of the earlier contributors to the crisis was the widely cited article published in 1986 that supported the use of opioids to treat non-cancer pain. A few years later, in the mid-1990s, the American Pain Society initiated a campaign to include pain as the fifth vital sign to improve patient care. 1 year later, the American Pain Society also partnered with the American Academy of Pain Medicine, released a consensus statement endorsing the use of opioids to treat chronic non-cancer pain. Over the next 6 years, Purdue Pharma began providing financial support to both the American Pain Society and the American Academy of Pain Medicine, amongst other influential groups. And in turn, these groups all advocated for more aggressive identification and treatment of pain, especially with opioids. In 2011, we saw a 900% increase in the number of patients seeking treatment for opioids. And in 2014, opioid overdose was named as one of the top 5 public health challenges for the US. But people weren't dying at the exponential rate from heroin and oxycodones as they are now. As you can appreciate from the graph to the left here, the rise in mortality from opioid overdose was proportional to the rise in opioid sales and treated admissions, rising at approximately a linear rate between 1999 to 2010. However, just the previous slide, please. However, when we are looking at the graph now to the right, we see that the rise in opioid mortality suddenly becomes exponential around 2015. But why? What caused this? Why is it that the opioid mortality suddenly skyrocketed despite their presence on the global drug market for decades? Next slide, please. So how did we come to a point where the deaths from the opioid crisis are overpowering the deadliest pandemic since the Spanish flu? Well, the common consensus would agree that fentanyl has entirely changed our landscape that we face for treatment of opioid use disorder due to its high potency, availability, and the high rates of contamination. Next slide, please. We have a lot of data to support the initial phase of the opioid epidemic was characterized by an increase in diverted pharmaceuticals. However, as the opioid crisis developed, non-pharmaceutical fentanyl entered the market as a heroin additive. And we are seeing a rise in death that has been associated with the rise in fentanyl. In this observational analysis by Baldwin et al. In 2018, a strong positive relationship was found between the number of fentanyl samples seized by law enforcement and the total overdose deaths, as well as being between seized fentanyl and the fentanyl detected overdose deaths. These findings were consistent in American populations. Next slide, please. And this is supported by provincial data that we presented for you today. As you can see, the graph on the left shows the exponential rise in opioid-related deaths, which we showed a few slides ago. And the graph on the right shows these number of deaths that were related to fentanyl use. It's not difficult to appreciate the common trajectory between the two.
Sorry, I was on mute. So we've talked about how the opioid crisis came about and the impact of fentanyl and COVID-19 on this crisis. Next, we're going to be summarizing some research conducted here at McMaster, employing data from one of the largest prospective cohort studies to date to help paint a picture of the high-risk clinical profiles associated with relapse and dangerous consumption. Next slide. So the data I'll be presenting to you is collected from an ongoing prospective cohort study titled Genetics of Opiate Addiction. This is a study I was directly involved in during my graduate training. And in this study, data was collected from the Canadian Addiction Treatment Centers across more than 30 sites in Ontario, and it's led by Dr. Zena Salmon. Now, this study employs a multi-center prospective cohort design with 1-year follow-up. We included all patients 18 years and older receiving treatment for opioid use disorder, and this could include any treatments, methadone or Suboxone. Now, patients could enter the study at any stage in their treatment, and they're followed for 1 year thereafter. Urine drug screens were obtained as per usual protocol on a weekly and biweekly basis, and assessments were done every 3 months, which included the Maudsley Addiction Profile, which measures addiction severity, drug use patterns, physical cravings, as well as health risk behaviors. So far, we've actually recruited over 4,000 patients since 2012. Next slide. Now, we are mainly interested in predictors of treatment outcomes, including treatment retention, continued illicit substance use patterns, injection drug use, as well as physical cravings. One of the main outcomes we're interested in, and that you'll hear us refer to through most of this presentation, is high-risk opioid consumption. Now, we define this as patients who had more than 50% of their urine drug screens positive for opioids during that 1 year of follow-up. Next slide, please. Now, based on the data we collected and analyzed, we were able to identify predictors of poor treatment response and build a clinical profile for high-risk patients. Next slide. Now, in our first study, we found that patients with chronic pain were significantly more likely to continue using opioids while on OST, and they had 4 times higher odds of engaging in high-risk consumption patterns than those without chronic pain. Next slide. Now, amongst patients reporting cannabis use during their methadone treatment, comparisons were made to evaluate whether cannabis use patterns, specifically daily use versus occasional use, were associated with concurrent opioid consumption patterns. And we actually found that daily cannabis use was associated with 40% lower odds of using opioids during treatment. So it was actually protective. Next slide. We also established important predictors of accelerated time to relapse among patients receiving methadone for opioid use disorder. In this work, we employed a Cox proportional hazards model to estimate time to event data, specifically time till relapse. And the important predictors associated with a shorter time till first opioid use included consumption patterns such as injecting drugs. Additional predictors included illicit benzodiazepine use, as well as older age of onset of use. Next slide. The slide before that, sorry, yeah, I was like, oh, we went too far. No, next slide, yes. So amongst patients receiving Suboxone, we actually found that being in treatment for longer and being on higher doses was protective against relapse. And similar to patients on methadone, we found a history of IV drug use was associated with increased rates of relapse, and there was no association between cannabis or benzodiazepine use on relapse rates in this particular study. Next slide. So looking specifically at sex differences, we found that sex differences were evident in polysubstance use, legal involvement, and employment status among men and women receiving methadone treatment. We actually found that women were less likely than men to use alcohol or report arrests, but they were more likely to be unemployed during treatment and use amphetamines during treatment. Next slide. We also found that starting opioids at younger ages, specifically before the age of 18, was more likely to contribute to physical or psychiatric comorbidity later in life. And the most commonly reported physical comorbidity included hepatitis. Next slide. Now, in fact, in our study, data showed that 1 in 4 people suffered from chronic liver disease, and patients with chronic liver disease were 68% more likely to demonstrate high-risk consumption patterns. And interestingly, we found that being on a higher dose of methadone and on treatment for longer was protective against the long-term effects of chronic liver disease, suggesting improved control and as well as stability on treatment. Next slide. Now, in our most recent paper, currently in press with the Journal of Addiction Medicine, we actually performed a subgroup analysis specifically in patients with Hep C among those with chronic liver disease. And as anticipated, we found those with Hep C had a higher burden of comorbid disease with increased rates of chronic pain, epilepsy, and HIV in comparison to the non-Hep C matched counterparts. In fact, our propensity match analysis showed that 35% of patients with Hep C were found to have dangerous consumption patterns and compared to the propensity match patients without Hep C. Next slide. Now, sex-specific examination of risk factors revealed that females incurred a 3 times increased risk for dangerous consumption patterns, and it actually demonstrated sex to be an effect modifier such that the association between Hep C as well as dangerous consumption was entirely driven within the female population. So in female patients and male patients were also found to have variation in their risk factors. Females were protected by older age, higher doses, and where men were actually at increased risk based on their IV consumption patterns. Next slide. And within our study population, we actually found that 80% of patients had at least one physical or one comorbid psychiatric disorder. Sorry, my emails are going crazy. We found that 80% of patients had at least one comorbid psychiatric disorder in addition to opioid use disorder, and that 42% of participants had at least one comorbid substance use disorder in addition to opioids. We found that the presence, though, of any psychiatric comorbidity wasn't associated with increased rates of high-risk opioid consumption. And we did find, though, that concurrent tranquilizer and cocaine use was linked to higher rates of opioid consumption in this cohort with psychiatric comorbidity. Next slide. Now, in another analysis of 2,200 patients between 2018 and 2021, we evaluated outcomes between those receiving methadone versus those on Suboxone. And we actually found that patients on Suboxone were 60% more likely to obtain abstinence compared to those on methadone, and that they were 40% less likely to use amphetamines during their treatment. Next slide. So to summarize from the longitudinal prospective cohort study over the last decade, we've actually learned a few things. We've learned that there are certain factors in this study population that's associated with high-risk consumption practices. And these factors included chronic pain, earlier age of onset, the presence of chronic liver disease, especially in those with hepatitis, injection drug use, and concurrent illicit benzodiazepine use. On the contrary, we actually found that daily cannabis use, higher methadone doses, as well as longer duration in treatment and older age were protective against high-risk opioid consumption practices. Next slide.
So we've reached a turning point in our presentation here today. So far, we presented to you about 10 years worth of data. We've established risk factors for poor response to therapy, defined distinct profiles which may lead to dangerous consumption patterns, overdose, and death. But where do we go from here? And what are our treatment options moving forward? And what might be the best treatment? Next slide. Opioid substitution therapy, or OST, seems to be the mainstay globally for treatment of opioid use disorder. OST works by providing longer acting opioids to help reduce symptoms of craving and withdrawal and allow for patients to be comfortable while they stabilize their lives and attempt to safely taper down from opioids under medical supervision. Methadone maintenance treatment is one of the most popular treatment options around the world, and it is effective for improving treatment retention, reducing opioid use and overdose rates. There has been a shift in more recent years away from methadone, given some safety concerns around its tendency to prolong QT intervals and risk of overdose given its full agonistic effects. Newer treatments, such as buprenorphine naloxone or Suboxone, have gained popularity since 2008. Cost was initially a barrier to access for patients, as it has only found its way onto the formulary for ODSP in 2016. Suboxone is a partial agonist combined with an antagonist, lowering the risk of abuse and death. Other drugs, such as slow-release oral morphine or Cadian, and more recently, injectable buprenorphine, are also emerging as safer alternatives to methadone. A 2012 Cochrane review demonstrated similar efficacy for opioid consumption patterns between methadone and Suboxone, but lower rates of retention for Suboxone. Next slide.
As the options for treatment continue to grow and given the high risk for adverse outcomes within this population, finding the best therapy for these patients is definitely critical. Next slide. Now, there's many different outcomes that we can use to measure treatment effectiveness, and the two that are most commonly employed in the literature include continued opioid use, as expected, as well as retention and treatment. Now, we pay a lot of attention to drug consumption patterns since patients who continue to use opioids while they're on opioid substitution treatment are known to be at higher risk for overdose, fatal arrhythmias, and respiratory depression. We also pay close attention to the impact of opioid substitution treatments on retention, as well as it's a well-established that participants who drop out of treatment altogether and are not retained on treatment are at much higher risk of relapse, infection, and other infective complications, including bacteremia, sepsis, valvular vegetations, and actually ultimately mortality. Next slide. So in the past few years, there's been a few options in our arsenal for opioid use disorder treatments, as Elon's outlined. But how can clinicians decide between which treatment is the best based on the current evidence? Clinicians rarely make the choice between treatment and no treatment, as we see in our clinical evidence of treatment versus placebo as how most evidence is generated. And despite this, it makes combing through the evidence particularly challenging. And to truly answer this question, an extensive summary of the literature is needed with a focus on all opioid substitution and antagonist treatments. Next slide. Now, such a massive undertaking is a major project that I've been quite passionate about, and I'm going to take you through some of our preliminary findings of a systematic review and network meta-analysis to highlight the important methodological limitations that we're faced with when interpreting the literature and actually trying to specifically answer this question. Next slide. Now, before summarizing the results of the network study, we're going to briefly describe some of the foundations of network meta-analysis. So traditional meta-analyses, as you can see here, make direct comparisons between two groups. So for example, methadone to buprenorphine. Now, the issue here is what about other treatments that have never been compared head to head? So we talked about, methadone versus maybe an additional treatment such as injectable buprenorphine, or what about methadone versus more novel treatments like injectable hydromorphone? Some of these have actually never been compared head to head. Next slide. So, and that's exactly what my computer's frozen. Sorry, guys. Oh, sorry. And this is exactly where network meta-analysis comes into play. It provides us an opportunity to make indirect comparisons for treatments that have never been trialed head to head. In a network meta-analysis, you make these indirect comparisons leveraging the data from the studies of all of the direct comparisons. So if you have evidence from group A versus group B and group B versus group C, but you've never compared group A to if you have evidence from group A versus B and A versus C, but you've never compared B to C, you can actually leverage the data from the other studies to inform this comparison. Next slide. So to gather information for a network meta-analysis, we actually completed a large systematic review to identify all the trials evaluating treatments for opioid use disorder. We allowed for a very relaxed inclusion criteria, placing no restrictions on the trials based on outcome selection. And upon screening over 6,000 studies, 60 trials were ultimately eligible for inclusion into this review, representing data on over 13,000 patients across 16 different interventions. Next slide. So given the variations in defining and measuring treatment effectiveness in patients with opioid use disorder, the only outcome we could actually meaningfully compile together was treatment retention. How many patients were still on therapy at the end of the trial? So among the 60 trials meeting eligibility criteria for our study, only 28 provided sufficient data for the combined statistical summary of treatment retention, and the rest were only summarized qualitatively due to the inconsistencies in measurement. Next slide. So as we just mentioned, across the 60 trials, 25 studies evaluating 16 interventions provided data that could be meaningfully compared statistically. And I provide here a summary of these studies in a network plot. So to interpret the plot itself, I'll direct your attention to the blue circles. So each of these blue circles or nodes represents a different treatment, and the size of the node itself actually reflects the number of studies within that corresponding treatment. And as you can see above, the largest node is high dose methadone, and it represents combined data from 2,800 participants from 25 trials. Other interventions assessed in this network included methadone, Suboxone, naltrexone, and even injectable heroin. Next slide. So briefly, and not to overwhelm you too much, this is actually a matrix of all the effect estimates across the 16 interventions for the outcome of treatment retention. A total of 256 comparisons were made. And as you can see, I've highlighted in red specifically the comparisons that were statistically significant. Now, I can direct your attention to the most left column. And in this column, heroin demonstrates the strongest effect over other therapies for improving treatment retention. And in fact, heroin was one of the only treatments tested that was found to be actually statistically significant against other opioid substitution treatments in the plot. And you can also actually see highlighted in red at the bottom row is reflective of comparisons made against placebo, of which not even all the treatments were able to demonstrate an effect when compared against no therapy at all. Sorry. So next slide. Awesome. So the major issue we found after reviewing the evidence were challenges in selecting a good outcome as a surrogate marker of success. We do appreciate that treatment retention is an important aspect of therapy, and we discussed earlier the reasons for that. However, when considering retention in the context of clinical trials, especially when randomizing patients to receiving heroin, we felt that this outcome might be a bit biased and short-sighted, as it's guaranteed to show improvement. Of course, patients are going to keep coming back to your clinic because you're providing them their drug of choice at no cost at all. But what are the longer-term implications of this? Do patients want to attend a clinic multiple times a day to be assessed pre and post heroin administration? Are they going to be able to meaningfully hold down a job and relationships with such a demanding treatment schedule? What about the other aspects of a patient's life or goals of therapy that aren't captured by retention? Maybe heroin keeps you coming back to clinic, but what about the rest of your life? Next slide. And that's kind of one of the big questions when you look at the literature as a whole. Given the complex nature of opioid use disorder and the rising number of treatments available, there's no gold standard measure of treatment effectiveness. And we've seen that by just carefully combing through the literature. But results from our systematic review actually demonstrated that each successive trial is measuring a different set of outcomes which are supposed to reflect success. And most of them are just in arbitrary or opportune terms that are most important for the trialists themselves. This is really prohibitive for making meaningful comparisons between the different treatments. Next slide. So where do we go from here? We sought to describe the different outcomes employed across all of the clinical trials and evaluate whether a discrepancy exists between treatments considered important to patients and whether the treatments that are actually measured to demonstrate effectiveness as measured in the literature are consistent with what patients are finding important. And to do this, we actually did a mixed method study. We used the data from the systematic review to actually go through all these trials, find out what outcomes are being used. And then we actually went to patients and asked them, are these reflective of what you find important? Next slide. Now, when we actually went through the literature, it was truly a mess. Across the 60 trials evaluating interventions for opioid use disorder, over 20 distinct different outcomes were used, employing over 100 different measurements. For example, an outcome like continued opioid use would not only be measured differently across studies, so some studies using urine tox screens, other studies using self-report, it was also just defined differently. Some studies actually reported that patients were using opioids if they just had a single positive urine, where other studies actually would require cutoffs. So if patients had more than 10% of positive screens, then they would consider a positive user. Now, the discrepancies in outcome definition and measurement and reporting applied to all the outcomes we assessed, including employment status, involvement in criminal justice system, as well as health risk behaviors, including sexual practices. Next slide. Now, when we actually posed the question to patients, we found a very distinct answer in what they determined to be important in terms of their goals of treatment. They actually focused a lot about being off treatment altogether, which is reflected in this one quote here. I want to be clean. To me, I'm sober right now, and I've been sober for 2.5 years, and I haven't touched the drugs for 2.5 years. And at the end of it, I want to be off methadone completely, but I want to be able to taper down till I no longer need it anymore. I want to look back and say it was just a phase in my life. I want to get off it completely eventually. Next slide. So in fact, from a sample of 18 patients undergoing OST that we had interviewed, you can see the outcome that was ranked as the highest priority for patients was abstinence from opioid use, with 47% of patients reporting it as the most important outcome, which exceeded the other outcomes by far. But most importantly, please note here that the most commonly employed outcome in the literature, retention and treatment, wasn't even ranked as important among these patients. Next slide. So these highlight a major lack of consensus in our evidence base when it comes to determining the appropriate endpoints for establishing treatment effectiveness. Individual and population level decision-making is being guided by a standard of effect considered useful to researchers, but in direct conflict with what our patients are finding important. Next slide. But our story doesn't end here. So we've shown you many of the issues with measuring treatment effectiveness in the literature, and we've showed you that patients don't necessarily agree with the outcomes that we're using to measure treatment effectiveness. But what about the directness of the evidence and the external validity? Whom was this evidence even generated in? Who is the evidence even generated in? And whether or not this evidence that's used to inform evidence-based decision-making is actually being generated in patients that we would find in our clinics. Next question. Slide. So this is actually a question that I looked at as part of my COMPS project, and we actually evaluated the question employing data from that original systematic review. We went back to those 60 trials, and we actually extracted the eligibility criteria to see who is this evidence even generated in. And then we went even further as to apply those criteria just to a general sample of the GENOA participants to see of these kind of general group of patients who would be eligible to be included in the evidence that's being used to guide our treatment decision-making. Next slide. And the results were very surprising. So we actually found the majority of trials used incredibly restrictive exclusion criteria. For instance, the majority of studies that are being used to inform our decision-making are excluding patients with psychiatric and physical comorbidity, rendering the data inapplicable to actually over 70% of that GENOA participant sample. and a little less than 50% of the trials excluded patients with concurrent alcohol and other substance use problems, or those taking psychotropic medications. Now, these criteria were incredibly restrictive, and in some cases, a single criteria itself would render more than 70% of our general sample of patients that were found in that GENOA cohort ineligible for inclusion, as we highlight in the rightmost column. Next slide. So far, we've covered a bit of information, as you can see, and we've shown you that heroin is the best treatment for keeping patients in treatment. We've demonstrated the majority of trials employ endpoints to establish effectiveness, which aren't in keeping with patients' goals of care. And finally, we showed that our large body of evidence to date has been generated in a sample that's barely recognizable to the type of patients we'd actually see in clinic or in hospital. Next slide. But where we go from here, well, we'd hope that as healthcare providers, we can rely on guidelines that relay these important methodological flaws in the interpretation of the data from trials. And that was exactly the next project. Next slide. When we actually go to the evidence and evaluate the current opioid substitution therapy guidelines across North America and Europe, we can look to see whether or not these important limitations that I've raised that are inherent in the literature are discussed. Next slide. And we were super surprised to find that Canadian American guidelines relied on out-of-date systematic review evidence. They made strong recommendations based on the trials that I showed you earlier, which employed very restrictive inclusion criteria. And they made recommendations actually based on a fraction of the available evidence. So out of those 60 trials, most of them only include 20 of those trials. And in fact, the guidelines often lack disclaimers to warn clinicians about the restricted nature of the evidence being used to inform the recommendations. And we should mention that we've also there's been multiple guidelines published since this study was done. And I haven't critically appraised the most recently published guidelines, but I do still suspect that some of these limitations would persist given the nature of research in this area. Next slide. But to really highlight how unrepresentative our current body of evidence is, we actually went back and searched the guidelines and extracted exactly which trials were used and cited in their recommendations. We then applied those eligibility criteria from those trials to, again, that general sample of patients, just to see how many patients would have been eligible to be in the studies used to inform the evidence. And the results were incredibly disheartening, where the totality of evidence used to inform our current clinical practice would have been applicable to at times 9 patients in the GENOA cohort. Next slide. So overall, I would say these findings are pretty big. We present to you today the totality of the evidence, which is plagued by highly stringent inclusion criteria, small sample sizes, and a lack of consensus over effective outcomes, selective reporting, and ultimately short follow-up time. These methodological shortcomings highlight the need for new assessment strategies for opioid use disorder. We need to determine what the patient-important outcomes are and make sure we're measuring them. And we also need to consider moving forward with maybe a standardized set of outcome measures that all future trials could employ. Methodologically, there's still a lot of work to be done. Next slide.
Now, stepping away from an in-depth review of the evidence, we're going to end this presentation sort of shining a light on an inpatient perspective, an important perspective lacking from much of the data presented and from randomized trials to date. Includes the perspective and clinical course for patients with opioid use disorder admitted to hospital. Looking specifically at this question, Dr. Leslie Martin has spearheaded an incredible project, working closely with the Peterborough Center for Addiction Research, taking a deeper look at the clinical and demographic trends observed amongst patients admitted to the hospital and seen by our inpatient addiction service. Next slide, please. Just a brief pause to note the team that we do have here in Hamilton. So this is our addiction medicine inpatient service team led by Dr. Leslie Martin, Dr. Robin Lennox, and Dr. Tim O'Shea. The team continues to grow rapidly. And as you can see, there's a lot of new faces. Next slide, please. To briefly introduce this program, it is an inpatient addictions medicine consultation service. It is currently providing inpatient consults across at least initially 2 hospital sites, the Hamilton General and St. Joe's. It has recently expanded to include consults for the OB populations at Mumsy and as well at Juravinski. The service itself was formalized in 2017 and has provided over 700 consultations to date. Currently, Dr. Martin has led a program evaluation, which includes a retrospective review of all the consultations up to 2021. Next slide, please. A retrospective chart review is undertaken to formally evaluate the inpatient addiction service. Each consultation since the formalization of the IAS was identified, undergoing a formal chart review, employing standardized pilot tested forms to obtain important demographic and clinical characteristics of the population served. The primary aims of this evaluation were to describe the population, clinical course, and outcomes for patients seen by the inpatient addiction service. Next slide. With respect to data collection, important demographic characteristics were identified, including age, sex, hospital location, income, as well as clinical comorbidities and reason for admission. Variables of interest were identified to be death, leaving AMA, ICU admission rate, and readmission to hospital, as well as pregnancy. The most detailed collection of information pertained to substance use, as well as health risk behaviors and consumption practices. All data was stored in REDCap. Stata was used for analyses. So the data presented here is reflective of 411 individual patients that were admitted since 2017. Of the patients charts reviewed, 50% were female with a mean age of 38 years old. 52% of patients were attached to a primary care provider at the time of admission, which increased to 56% at time of discharge. As well, approximately 2% were transferred from a penitentiary facility. Comorbid conditions are listed above. As you can see, most frequently reported condition includes hepatitis C infection at 33%, followed by chronic pain at about 15%. Next slide, please. 27% of patients reported ODSP as their primary source of income. This accounted for the majority of patients reporting their source of income. Ontario works or unemployment was the second most common source of income reported. Less than 10% of patients were employed, and close to 15% of patients reported no source of income at all. The remaining reported various informal sources of employment, which could be informal employment or labor jobs, as well as sex work. It is important to note source of income was not reported or missing from the chart on close to 25% of patients. In terms of reason for admission, we can see that sources of infection appear to be the most common admission diagnoses. For example, bacteremia, infective endocarditis, and soft tissue infections account for close to 15% of admission diagnoses per category. Pooled together, they would be about 50% of reasons for admission to hospital. The other category was notably high as well, and also indicates some issues with some of the quality of reporting in the charts, as well as development in retrospective data collection methods. With respect to treatment utilized in hospital, given the overwhelming number of infection-related admissions, it's not surprising that antibiotics are coming in large with over 30% requiring IV antibiotics and close to 20% requiring oral antibiotics. This may be more reflective of quality of documentation, but surprisingly few admissions actually used or required wound care services during the admission, although this is suspected to be an error in reporting. Next slide, please. Analysis of current opioid consumption practices was unsurprising, with over half of participants reporting fentanyl as their opioid of choice. Heroin and hydromorphone were close in second place, approximately 20% each, but still fentanyl was the largest. With respect to routes of consumption, more than 50% of patients are seen using IV access for opioid consumption, with inhaled or oral being next. Now, one of the major performance indicators looked at included leaving against medical advice. As a service, the inpatient addiction medicine team is working to create a safe, trauma-informed environment for patients with substance use disorders. Reducing hostility and preventing patients leaving AMA is an important objective of the team. Many efforts are made, including addressing withdrawal symptoms early, meeting patients where they are in terms of substance use needs, helping ensure an atmosphere free of hostility, being mindful of calls to security, as well as unwarranted searches of property. So for our data estimates, a very high percentage of patients were in fact leaving AMA at 17%, as well as needing readmission frequently at about 42% within the 4-year period. Other variables of interest included deaths, of which 7 individuals have died over the past 4 years. Evaluation of the acuity and level of complexity associated with these patients is clearly indicated by the number requiring ICU, which is around 34% requiring ICU services. The preliminary data highlights that there is no question the patients seen by the service are sick and often leaving under suboptimal circumstances, requiring admission frequently.
So we are clearly on a concerning trajectory. I just want to bring you back to this initial figure that within the first 3 months of 2021, we've already reached close to the cumulative numbers of deaths from opioid overdose that was seen at the initial onset of the opioid crisis. Some of the points we just want to highlight is that opioid-related deaths is one of the leading causes of mortality for people under the age of 50. And this rise in mortality has been linked to the increased use of fentanyl. Within this population, patients with chronic liver disease, HCV, chronic pain, earlier age of onset, and injection consumption patterns perform worse across the majority of outcomes. We're no closer to determining optimal therapies for a patient with opioid use disorder. And this is heavily, our research is heavily influenced by highly restrictive inclusion criteria, limiting the generalizability of evidence and the major inconsistencies in the measures used to evaluate the effectiveness of opioid substitute therapies. At an individual and population level, decisions need to be guided by a standard of effect considered useful to researchers, and yet this standard is in direct conflict with the outcomes patients deem to be the most important. Future research is needed to establish a standardized set of outcomes and ensure guidelines highlight major methodological weaknesses in their interpretations and recommendations. There is clearly a lot of work ahead to improving the lives of patients with addictions, but as a clinical service and program of research, we are certainly doing our best to try and contribute to the solutions. Thank you so much for your attention. I'd like to now open the floor to questions.
Thank you all. That was a fantastic presentation and a very important topic. There are some questions. I know that Dr. Gerstein has raised that he'd like to ask a question verbally. Dr. Gerstein.
Did we lose him? I think you have to somehow allow him to speak.
Oh, yes, that's what I'll. One second, let me just. I'll do that. Sorry.
Dr. Martin has her hand raised. I didn't mean to do that. I was trying to see if I could help let him speak on my end.
Dr. Gerstein, I've opened up your ability to speak.
Maybe.
Okay, can you hear me?
Yes.
Perfectly.
Okay, thank you very much, Mohammed. First of all, I want to reiterate that I thought that was a nice, very well done, comprehensive review of things. Listening to it in an area that I'm not expert in, to me, the most clear message that I'm hearing is that there is and the meta-analysis that you present and everything clearly shows that there's no good evidence in this area, and that one can keep meta-analyzing and do meta-analyses of inadequate evidence, and people write guidelines based on inadequate evidence. Those are not evidence-based guidelines, they're expert-based guidelines and opinion-based guidelines. And the message I'm hearing clearly that there's a crying need for good, new, large trials with patient-relevant outcomes, such as death, complete discontinuation, that balance side effects versus not, comparing new versus oral therapies, older therapies, et cetera. And so my question is, are those trials being done? because just doing more of the same is going to just keep us in this kind of morass of ignorance, which is what I think I'm hearing. And so I think it's, what you presented to me is a great background for a CIHR grant that says, therefore we need to do the trial. So my question is that going to happen?
I guess to approach that question, I really hope that will be my future career, and I hope nobody jumps on it too soon. So I hope me and Dr. Martin will write a grant in the next couple of years. But there's definitely new evidence emerging, not very large clinical trials yet. Like on clinicaltrials.gov, there's definitely some registries, but no like preliminary data, and nothing's actually been released probably in the last 10 years in terms of large trial. Even stuff like considering like with Suboxone, we use like a microdosing protocol, and that actually needs to have a clinical trial, which they're going to be starting to run in Vancouver soon. And we're still using evidence on case series to inform that kind of practice. So it's coming, but in terms of larger stuff, all of this also needs to be redone when you think about in the new fentanyl era. Like I know Dr. Martin can definitely speak more about this, but even the doses that we're needing for methadone and Suboxone for these patients are much higher than any of the doses used in the previous clinical trials. So we definitely, even just based on the types of drugs that people are using now and the co-ingestions and the comorbid substance use with amphetamines, we need to kind of go back and redo the original studies. But yes, I hope so.
Leslie, you have enough to do to write the grant right now. And I'm not talking about trials where the outcome is pain relief. I mean, that's easy. It's trials where the outcome is death or total off drug, off any drug for 2 years, or something like clinically important outcomes that means something. So, registries will never tell you this, everything you need, anyways, I think you've got enough. You could write the grant now and it would probably get really well reviewed.
Thank you, Dr. Gerstein. Thank you. That would be awesome.
So now there's another question. Dr. Kernu has brought this question up. How to pick patients we can help the most, and what do we do in a perfect world? And he's followed up by asking, is cannabis good or bad?
I mean, it's a pretty big question. I would say from the first question being, how can we pick patients and how can we do good? Sorry, how do I answer? How do we pick the patients we can help the most, and what to do in a perfect world? So how to pick the patients we can help the most I think that would just be generally the entire patient population. I think that one thing that hasn't been looked at enough is certainly the sickest patients. So I think a lot of our evidence is generated in this clinic environment. So patients starting opioid substitution therapies and seeking help for addiction in the community. So they're already at a space where it's very different than a lot of the data that we were presenting from Dr. Martin's study and the patients that her service sees. Is you're seeing patients that are probably in the most dire need. And sometimes, they haven't even come to the part where they're out in an outpatient going to a clinic trying to start this. We're actually meeting them at a point where they're the most severe, where now you have a spinal abscess and you're having difficulties walking, or now you have infective endocarditis. And when you meet those patients there, you actually have an ability to kind of help them and make a big change in their trajectory. So I think definitely those patients, the sickest ones in hospital, is an area that we can certainly improve. And there's a big study going on with Dr. Robin Lennox and as well as Dr. Richard Whitlock. They're doing the second heart study where they're trying to connect these patients to almost a better seamless system where they'll get, like a caseworker, they're going to get a better connection to a family doctor. Because one thing we actually mentioned was a lot of these patients don't even have connections to family doctors when they come in and leave hospital. So there's definitely things that we're trying to do to help them or see if it works. And cannabis, good or bad? Maybe Dr. Martin can shed more light on this. I think the data is kind of it's, as you know, the quality of evidence isn't great. What we have seen is daily cannabis users don't use as much opioids in the GENOA study. And maybe that's because they're more comfortable on the cannabis. Maybe it helps with some of the withdrawal or craving effects. I'm not too sure. What do you think, Dr. Martin?
I'll just say stay tuned, because Tim O'Shea, James McKillop, who leads the Peter Boris Center and does a ton of research in cannabis, and myself are going to be doing grand rounds in the new year. And so I can ask him to include some of his cannabis research, because that's his area of focus. So stay tuned.
Any other questions from the group? You can put it in the question answer, raise your hand. We have about 3 minutes left before the rounds ends.
And thank you, Dr. Martin, for running the slideshow the whole time. I really appreciate that. Sorry, we had some technical difficulties at the beginning.
No problem. I just want to say great job, guys. Thanks so much for presenting today. Good.
Being that there's no more questions, we have about 3 minutes left. If there's no further questions, that was a wonderful presentation on a very, we have a question. The question is briefly what is the motivation for a lot of the patients who come in for why they're taking their drugs? And is there other fixable issues for that?
So, I mean, I think this question kind of gets at the heart of the problem. And I think that it is most definitely a multifactorial thing that contributes to people using substances. Certainly people do use them to cope, and we can't change people's lives. And we definitely need governments and, thinking about improving social assistance, improving education, and but at the end of the day, people are going to have bad and traumatic things happen in their lives, and it can lead to substance use. And I think recognizing that and meeting these patients where they're at and trying to make sure that we have beyond just, drugs that we can prescribe that can help with the horrible cravings of withdrawal, which is something I don't think people appreciate enough. I think a lot of people say, why do they keep using? Why can't they stop? We see these patients come in and out of hospitals. Some services get annoyed with them. And I don't think people appreciate not only the psychological factor of trauma and the use of substances to cope, but also when the withdrawal is so bad that you don't care, you'll shoot into an infected arm, or you have a vegetation growing on your valve and you've gone for a surgery, but you're still going to use because the pain of withdrawal is that bad. I think that we need to recognize this as a much more severe disease, and being able to meet them where they are and just support them, and even just starting with the first thing of limiting the stigma. These clinics you go to, getting your treatment through a, bulletproof glass and having to pee in front of a camera is the most demoralizing thing. And we would never do that to any other patient population. So I think also just shifting where we're at and how we treat these people, moving away from punitive approaches would be ways that we can at least fix the services we provide. I can't fix people's childhood, but I can be more human in how I treat people and put your hand out and invest in these people early, because they'll surprise you.
Thank you, everyone. It's 9 o'clock. Wonderful discussion, and we'll end there. Have a wonderful day, everybody, and have a wonderful holidays season coming up.
Merry Christmas. Bye.